In this video, we'll try to develop a simple and clinical approach for discrimination between the different MRI sequences beyond the toughness and hardness of the physics. So let us start. First of all, we can categorize the whole MRI sequences into two main big families. The first family, or the first large group, called a spin echo sequence, and the second family or the second group called gradient sequence. And generally speaking, spin echo has advantage of it is higher resolution, but it has a longer time, so it is a long time scan. And gradient sequence has a lower resolution, but it is a faster scan. Okay, in this lecture, we'll develop two pathways for discrimination between the different MRI sequences. The first pathway, by looking to the parameters of the image. Through these parameters, you can identify which sequence you are dealing with. While the second pathway, looking at the image characters itself, the image itself, the pattern of the signals of the tissues within the image. Through these patterns, you will identify this sequence. So let us start the first pathway, identification the parameters of the sequence. Each family, either spin echo or gradient sequence, has three main parameters. The first parameter, what we call the echo time, the second one, what we call the repetition time, and the third one is the flip angle. Echo time and repetition time represented by milliseconds, while the flip angle represented by a degree. In the case of a spin echo, usually those parameters are much larger compared with the gradient sequence. From this diagram, we can see that those parameters belonging to the spin echo are much larger in their values compared with the same parameters of the gradient echo. However, the faster point to discriminate between the two families is to looking for the value of the flip angle. If you find the flip angle value equals 90 degrees, so you are dealing with a spin echo sequence. While if you find it less than 90 degrees, so you are dealing with a gradient sequence. And later on, you can examine the other parameters, either echo time or repetition time, and you will find those parameters are much larger in the spin echo compared with the gradient echo. This table easily demonstrates the large difference between the values of repetition time and echo time of spin echo compared with the gradient echo sequences. So for example, if we say we have a long repetition time in a spin echo, we'll notice that it will be more than 2000 milliseconds, while the long gradient sequence, TR, its a value about more than 100 milliseconds. There is a big difference between their values. And the same situation regarding the echo time. Another important table demonstrates the difference between the two families. The first regarding the flip angle, as we have mentioned before, it's 90 degrees only regarding spin echo, while it should be less than 90 degrees in case of gradient sequence. Another point, the angle in gradient sequence could be variable and usually less than 30 degrees. It could be 10 degrees, it could be 25, could be 15, so it's variable, not fixed as a spin echo. Also, spin echo is less susceptible to artifacts, so it has a better resolution compared with the spot gradient. And as we have mentioned, the acquisition time in a spin echo is long, so it is a slow scan compared with the gradient echo sequence. So let us start with the first family spin echo sequences and discuss in detail the commonest sequences we can deal with it in the practice, in the clinical practice. One of the commonest spin echo pulse sequences. There are two main pulse sequences almost present in all MRI studies. The first one, what we call T1 weighted image. The second one, T2 weighted image. Those two pulse sequences mostly present in all examination. Another sequence which is common, especially in the MCK, the speciality which what we call proton density. Let us discuss them and see how can we discriminate between them. Okay, as we are still in the first pathway in discrimination between the pulse sequences by looking the parameters, so let us check the parameters of those pulse sequences, T1, T2, and proton density. From this diagram, we can see T1 sequence usually has a short TR and short echo time, TE. TR about 300 to 600 milliseconds, while its TE it's 10 to 15 milliseconds. When we're looking for T2, it's long. It's TR by thousands, 2000 to 6000, and TE by hundreds, 100 and 150 milliseconds. So it's a long sequence. It has a long TR and long TE. While the proton density, it is an intermediate sequence. It takes the long TR from the T2 as T2 and take the short echo time from the TE. So we call it as intermediate sequence between both sequences. Thus, if I would like to obtain a T1 weighted image, so I will instruct the machine to obtain this image, and the machine will process itself and will process the parameters to obtain a T1 image by modification the TR and TE value within the known range of the T1 image. Like in this situation, TR will be between 300 and 600 milliseconds and TE will be between 10 to 50 milliseconds. And the same situation when I need to obtain a T2 weighted image or a proton density image, the machine will adjust their parameters according to the known range of these sequences. So this is another table demonstrate the main features of these pulse sequences and what we have mentioned before, what's short and what's long. And we can notice that T1 has short TR and TE, while T2 has long TR and TT, and proton density has a long TR and short TE sequences. So as we have described the first pathway for pulse identification, as we have mentioned before, through the identification of the parameters and knowing that with what they are mean. So we have another pathway, which is a more clinical pathway, and it's usually we are using in the clinical practice. And this pathway, usually we use it in absence of the identification of the parameter, through looking at the image signal characteristic, as we will talk and clear and describe these features in the next slides. If we would like to discuss the concept of the image formation, we find that this concept based on what we call the contrast resolution. Contrast resolution simply it's the ability of the machine to differentiate between different types of the tissues in one scan. For example, here in MRI, if we have 3 types of tissues as shown in this diagram, we can check this. The tissue number 1 release large number of signals, so the reflected image it will be more bright as long as the signal intensity increase in number, so it will give a bright signal and the bright area of the image. While if we check the tissue number 3, it gives a few number of signal intensity, so the image in this part it will be dark. While the tissue number 2, it gives an intermediate number of signals, so the degree of brightness it will be intermediate between the bright and dark areas. So as long as you can differentiate between the different types of the tissues, so what we call this is what we call the modality has high degree of contrast resolution, and this is one of the characteristic feature of the MRI in general compared with the other imaging modalities. Thus, when we apply the second approach of the pulse identification without parameters, what we call visual identification, and keep in mind that the concept of the image formation and contrast resolution, we'll find that the easiest way to discriminate between the different pulse sequences T1, T2, and proton density is looking for the fluid signal intensity. So we need to look for the fluid-filled spaces, especially in the abdomen. For example, in the abdomen, the fluid-filled spaces include the gallbladder, urinary tract, common bile duct, or CSF in the lumbar spine, or even a pathological free fluid like ascites or collection. And the characteristic signal of the fluid, it will be dark on T1 and it will be bright on T2, while on the protein density it will be intermediate like grayish-white near to the fat signal, as we will discuss later. Let us check this diagram, which indicates the degree of brightness of the fluid and of the fluid signals on the three different pulse sequences T1, proton, and T2. We can notice that the T2 had the fluid signal will be bright, while on the T1 the fluid signal will be dark and the proton density will be intermediate signal. So let us check these signals in a real image of MRI. So this aerial image of MRI brain axial cuts, including the three pulse sequences T1, proton density, and T2, and the yellow arrow refers to the CSF. We can notice that the CSF signal pattern and signal changes on each pulse sequences. On T1, the CSF it looks dark on signal, while on T2 it looks bright in signal, while in proton density it is intermediate in signal. So this is example of how the fluid signal and the degree of its brightness it change according to the pulse sequence used. Another example through the abdomen, there are two cuts, axial T1 and T2 of the abdomen almost at the same level. And if we remember the fluid-filled spaces in the abdomen, we remember that which is important is the CSF within the lumbar vertebrae and spinal canal. If we check this circle, which indicates and refers to the spinal canal, and compare it on T1 with T2, on T1 we'll find that the CSF surrounding the cord or the conus medullaris is low, dark in signal, while on T2 it's bright in signal. And it's very important because sometimes you are confronted with special cuts or selected cuts. You don't have the normal fluid-filled spaces. So remember to check the CSF of the spine. Another clue of the image when look for the yellow arrow refers to the gallbladder. The gallbladder on T1 has a low signal or dark signal, while on T2 has a bright signal. So this means that the fluid is dark on T1, whatever the imaging of the body parts, and it's bright on T2, whatever you image each body part. So what about the normal signal of the remaining tissues through the abdomen? This diagram shows the normal signal pattern on T1 and T2. If we take an example, find that air and the cortical bone and the fast flowing blood are or have dark signal or low signal on both T1 and T2. So it's not suitable to use these tissues or these items as a discriminator because it doesn't change these tissues will not change from T1 or T2, and that's why we are looking for fluid. And you can check the other items and know what's the bright, what's the intermediate, what's its low for comparison on T1 and T2. So here is another example, and if we apply our approach for recognition between T1 and T2, we can notice that the white circle refers to the low signal intensity of CSF spaces on T1, while it is bright on signal on T2. So we have a T1 on the left hand of the image and T2 on the right hand of the image. Also, we can notice a different arrows. The green arrow refers to the subcutaneous fat, while the yellow arrow refers to the intra-abdominal fat, peritoneal fat, and the blue arrow refers to the retroperitoneal fat. We can notice those fats, usually the fat has a special signal intensity. It's high on T1 and high to intermediate or intermediate to high on T2. And the fat signal is very important because we will discuss it in another sequences. Again, another example of axial T1 and T2 of the abdomen almost at the same level. T1 because it's the CSF space has a low signal, while on T2 the CSF space has a bright signal. But if we look to the blue arrow, which refers to the lumen of the bowel loop, we find that it's low on T1 and on T2 because it contains gas. And as we have mentioned before, the gas and the cortical bone has a low signal intensity on both pulse sequences. The yellow arrow refers to the fast flowing structures like blood in the large vessels. Here in the refers to the aorta, which has a signal void on both T1 and T2, indicating a low signal. So these structures, we cannot consider it as a discriminator because it has the same pattern of signal on both pulse sequences. So we still fix it with the fluid signal. Now we can know how to discriminate between T1 and T2 pulse sequences. So what if we would like to apply a new sequences or a new technique for further examination? There is a common sequence or techniques, what we call the fast suppressed imaging sequences. These sequences simply based on cancellation of the normal high signal intensity of the fat and to become dark, either subcutaneous fat or abdominal fat. So what's the value of this sequence? Why would like to use it? Usually we use this technique for two main reasons. The first reason to characterize the tissue, if there is a lesion contains fat or not, because this will narrow our differential diagnosis. If the lesion contains fat, so we have a differential diagnosis differs from a lesion without fat content. Additionally, another reason, the fat suppression technique enhances the contrast resolution of the image, especially with post-contrast studies. The fat suppressed imaging could be used with T1 and T2 weighted sequence, as we will discuss later. Okay, the fat suppressed imaging could be applied with the gradient and spin echo families. However, to select the best sequence to apply, there are many factors. You should determine it before choose the right fat suppressed sequence. For example, you should ask yourself why you need this fat suppression, or you need it for tissue characterization or to enhance the contrast resolution with the post-contrast studies. Another important point about the amount of the fat in the tissue being studied. You need to study macroscopic fat or microscopic fat. Also, what's the field of strength of the magnet? Are you using a high field strength like 3 Tesla or low field strength like 1.5 or 0.5 Tesla? Also, the homogeneity of the magnetic field. If the part of the body part of the examination, like if there is a metallic implant, so it will give some heterogeneity of the field of the image. So there is some sequences preferable to use it with the metallic implants and some are not. So these important point should be kept in mind before the selection of the suitable fat sequence, fat suppressed imaging sequence. Usually there are 4 fat suppressed imaging techniques used, especially in the body imaging: fat sat technique, shock T1 inversion recovery, or what we call a stir sequence, chemical shift, and Dexo method. The first 2 techniques, fat sat and stir sequences, are related to spin echo family, while the chemical shift and Dexo method related to the gradient sequence family. Okay, if we check an example for T1 and the fat saturation technique, this is a T1 axial cut of the abdomen, white T1, because CSF, as indicated by the white circle, is low, and the yellow arrow refers to the gallbladder, which has low signal intensity, so it's T1. And the blue arrows refers to the high signal intensity of the normal fat, either the subcutaneous fat or the intra-abdominal fat. While if we apply the fat SAT technique, we'll find that all the fat, either subcutaneous or intra-abdominal fat, becomes suppressed and has a dark signal. So this is what we call the fat suppression technique. Another example for T2 and fat saturation technique. On the left hand image, this is a T2. Why T2? Because this is MRI of the pelvis and at the region of urinary bladder, and urinary bladder contains urine which exhibits high signal intensity on T2, so it is a T2 sequence. At the same time, the blue arrows refer to the subcutaneous and pelvic fat, and the green arrow refers to the bone marrow signal intensity, which consists of fat. It's usually high signal on T1 and intermediate signal on T2. When we apply the T2 with the fat suppression technique on the same level and at the same patient, we'll find that all the fat, either subcutaneous fat or the pelvic fat, and even the bone marrow fat of the hip bone on the pelvis become suppressed and become low in signal. This is what we call T2 with fat sat. This is another example of the fat saturation technique which reveal or indicate its ability for tissue characterization. If we noted that in the normal T2 sequence, there is a lesion deeply seated in the pelvis and exhibits bright signal intensity, while when we apply the fat SAT technique, the lesion lost its signal and become dark on signal. This means that this lesion has a fat component, and usually it is adnexial lesion, so we can characterize and narrow our differential diagnosis for a fatty containing adnexial lesion, and the most common situation in this case it is a dermoid lesion. So from here we can characterize the pattern of the lesion and we can make a suitable diagnosis. A last example of this section to compare between both images of T1 and T2 fat saturation. On the left hand side we can notice that this is a T1. Why T1? Simply because CSF is low in signal, so it is a T1, while on the right side we find that CSF is bright on the lumbar spine, so it is a T2 image. So what about the fat? We can note that the fat at both images are suppressed, has a low signal, either subcutaneous fat or the abdominal fat. So we are dealing with a T1 with fat SAT and T2 with fat SAT. Finally, thank you. Till we meet again in the coming video to continue this subject. So please don't forget to subscribe and activate notification option to be notified when the video is ready. Thanks.